Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
This program is presented by Medscape Education Global.
Hello, my name is Lorenza Rimassa. I'm Associate Professor of Medical Oncology at Humanitas University and Humanitas Research Hospital in Milan, Italy. Welcome to this program titled How I Treat Advanced Hepatocellular Carcinoma, Mastering Immunotherapy for Optimal Outcomes. Joining me today is my colleague Stephen. And Stephen, would you like to introduce yourself?
Hello, thank you, Lorenza. Hello, everyone. I'm Stephen Chen, professor at the Department of Clinical Oncology at the Chinese University of Hong Kong in Hong Kong.
Thank you, Stephen. And in this activity, we are going to review the currently approved and upcoming immunotherapy options for patients with advanced HCC. We are then going to discuss in detail 2 patient cases with advanced HCC, focusing on the patient and disease considerations when we select an immunotherapy and the adverse events that may occur when receiving treatment. Now, Stephen, what are the latest clinical data for the approved IO-based options for patients with advanced HCC?
So thank you, Lorenza. I think we have several from the phase 3 clinical trials for the IO-based options or regimen for advanced HCC. The first one was the IronBrave 150, which is a phase 3 clinical trials randomizing the patient with advanced HCC to the atezolizumab and bevacizumab, and the control arm was the sorafenib. The key results show that for the both predefined primary endpoint, i.e. the progression-free survival and also the overall survival, both did show the improvement favoring the atezolizumab and bevacizumab when compared to the sorafenib. And also there was a numerical improvement in the response rate favoring the atezolizumab and bevacizumab. One point I'd like to point out about this clinical trial is that all patients need to undergo the baseline endoscopy to study and rule out any high-risk varices. And the second clinical trial is the Himalaya clinical trials, which is a phase 3 trials randomizing the patient to arm A, which is 1 dose of tremelimumab and regular dosing of durvalumab. And the second arm is the only durvalumab. And the third arm is the sorafenib. The key result was that the arm A, which is the strike regimen, the tremi plus durva, did show an improvement in the primary endpoint, which is the overall survival, as compared to the sorafenib. And for the secondary analysis, the arm B, the durvalumab, also showed non-inferiority in terms of overall survival as compared to the sorafenib. So both of these regimens were approved by the US FDA and also multiple regulatories in the world, and now generally considered both are valid options for the patient with advanced HCC. So Lorenza, we know that there are several promising immunotherapy regimens which also come out for the treatment of advanced HCC. Could you update us about these recent latest clinical trial results?
Thank you, Stephen. Yes, there are other phase 3 trials that are positive. The first one already presented is the Rational 301. You mentioned that in the Himalaya trial, there was also a durvalumab single agent arm. The Rational 301 tested the tislelizumab, that is a PD-1 inhibitor, for non-inferiority versus sorafenib, and the trial was positive. And in terms of overall survival, and also showed a better safety profile for tislelizumab versus sorafenib. This new option, tislelizumab, is not yet approved by the FDA or EMA, but is approved in other countries, and we will see if we will have a worldwide this option in the future. Then moving to the combinations or other combinations of immunotherapy, the CARS-310 is again a trial that has been already published and tested the combination of camrelizumab, PD-1 inhibitor, plus rivosiranib or apatinib, that is a small molecule against VEGF receptor 2. And again, the control arm was sorafenib. This trial was positive and showed an improved overall survival with a combination of camrelizumab plus rivosiranib versus sorafenib. The combination showed also quite high percentage of adverse events. Grade 3-4 adverse events were around 80%, but they were manageable. And this combination has been approved by the Chinese regulatory agencies, but it's not yet approved in Western countries. And this is probably due to the fact that most of the enrolled patients were from Asian countries and only 17% of the patients were from Western countries. We will see again if we will have a worldwide this combination. The most recently presented data are about the CheckMate 90W. That is a phase 3 trial, not yet published in full, but presented at ASCO and ESMO 2024. And in this trial, the combination of ipilimumab plus nivolumab with 4 doses of ipilimumab and then nivolumab, this combination was tested against tyrosine kinase inhibitor according to investigator's choice, and most of the patients, 85%, received lenvatinib. So this is the first trial that is mostly versus lenvatinib and not versus sorafenib. The trial showed improvement in overall survival with a combination of ipilimumab and nivolumab versus lenvatinib, and also a benefit and improvement in response rates with a long duration of response. There is no benefit in progression-free survival. This is something that we have seen also with the other IO-IO combinations. So this trial showed a benefit for ipilimumab plus nivolumab versus lenvatinib. There is something that we needed to better understand. That is the first part of the curves. For the first year, there is a higher benefit, a larger benefit from the TKI compared to the immunotherapy combination. But then in the overall, in the median overall survival and long-term survival, there is a clear benefit from the immunotherapy combination. So we will see more data in the full paper, and we will see when this combination will be available in clinical practice. Now we will discuss 2 clinical cases. Stephen, would you like to present the first case?
Sure, Lorenza. The first patient, as you could see from the screen, is a patient who was a 68-year-old man who was a chronic alcoholic, and also because of a history of a previous drug user, he was positive for the hepatitis C infection. In terms of the hepatitis B, he was negative for the surface antigen, but was positive for the antibody against the hepatitis B core antigen. But for the HBV DNA, it was undetectable. As you could see in the screen, the patient initially presented with a tumor in the right lobe of the liver, measuring 5 centimeters. After workup by our surgeons, and also we have discussed this case in the MDT, the decision was we may consider surgery, but we'd like to, because of small left loop, put the patient on 1 cycle of TCE first, and then followed up by the portal vein embolization so that we can induce the left loop hypertrophy. And then our surgeon could resect the right lobe of the liver. In terms of liver function, the patient had Child-Pugh A liver function, and the platelet count was normal. So unfortunately, the patient, as you could see after the TCE, there was a progressive disease with the extension of the tumor in the right branch of the portal vein, and also there's some satellite lesion developed around the main lesions. So in summary, this patient, despite initial presentation of more localized disease, but after TCE, the patient developed PD. So maybe I can ask Lorenza for your opinion. So would you consider this patient for some systemic therapy like IO-based as we discussed, or do you have other option for this treatment? And also, what patient and disease characteristics will you consider about this patient when you make the decision on the choice of the IO therapy?
Thank you, Stephen. I think the answer to your first question is yes. This is a patient who received a local regional therapy and showed disease progression with a tumor thrombus. So now it's BCLC-C. And I definitely consider this patient for systemic therapy and for an immunotherapy combination therapy. The characteristics that we have to consider when we select the systemic therapy are related to the patient. So the ECOG performance status, that is good in this patient. For instance, we have to consider comorbidities, concomitant medications. We have to consider the disease characteristics. In this case, there is a tumor thrombus, so we can consider this. We need to consider, as you mentioned, the upper endoscopy to look for varices, and if varices are there, we have to treat the varices or to consider what to do with the varices before starting treatment. And we have also to consider the liver function. This patient had a good liver function, Child-Pugh class A. We have to consider to check if the liver function is still good to start the systemic therapies. So different aspects. Patient disease characteristics, and for disease characteristics, I mean both the HCC characteristics and the underlying liver disease characteristics, and then we can select the best systemic therapy. In this case, I'm not sure if if the tumor thrombus is in the main portal vein. If this is in the main trunk, we cannot use a stride because this was not tested in this population, so we have to use atezobev. If there is no tumor thrombus in the main portal vein, then we can decide which is the best option for this patient.
Thank you, Lorenza. I think fortunately this patient had the tumor invaded to the right branch, touching the confluence, not yet into the main portal vein. But anyway, we have similar thoughts as you, Lorenza. In our MDT, we do agree that this patient had more advanced features and also refractoriness to the TACE. So we consider systemic. And fortunately, at that time, we have availability of clinical trials. So we discussed the choice of iron break 150 with the patient. So he kindly consented to this study. So we initiated the screening procedures for him, which didn't show any remarkable problems. The baseline upper endoscopy did show some grade 1 esophageal varices, but without any features at high risk of hemorrhage. So we consider this patient suitable for the iron break 150. So the patient finally was randomized to the experimental arm, which was the atezolizumab and the bevacizumab. So the patient during the treatment did develop some complication, namely the grade 2 hypertension, which treat him with antihypertensive drugs. Did have some grade 1 fatigue, and we put on conservative management. The patient did develop some degree of the proteinuria initially, but also more grade 1.
And Stephen, thank you for the presentation. I have some questions for you about this case. What role would the MDT have had in making your treatment decision for this patient? You mentioned you had a clinical trial, but are you used to discussing the MDT, the treatment? How is your clinical practice for these patients?
I think at this moment, if both both regimens are allowed and approved, I would consider either atezolizumab, bevacizumab, or the strike regimen in this patient. But at that time, back to 2021, we don't have strike regimen at that moment. So, and also for atezobev is more in the clinical trials. And of course, at that time, another option is monotherapy, the TKI, like sorafenib or lenvatinib. Obviously, nowadays, when we already have a 2 IO regimen, we know both options may not be the best because the patient may not have the tail, the response rate is not as high. So I would say if the patient were today's standard, we will either consider strike or the atezolizumab and bevacizumab or clinical trials. So these are the options that we are considering. And of course, the last point I'd like to make is we do see some patients with kind of downstaging or very good response after a few cycles of immuno, either atezobev or strike, that we may discuss again in the MDT to see whether we can proceed to some more aggressive like surgery or local ablative or local regional therapy.
Well, thank you, Stephen. And another question, do you discuss your treatment decision with the patient? How do you share your decisions with the patient in clinical practice?
So Lorenzo, this is a very good point. I think clinical trial is clinical trial, but when we discuss our patient, usually they're more concerned about, say, doctor, what's the chance that I can live long? What's the chance I can live long, like 3 or 4 or 5 years afterwards? So sometimes they may not be very interested in the median overall survival. And of course, we generally explain both the median OS and also the long-term survival rate, like 3 years or 4 years or 5 years if the data are available. Another key point that we'll discuss with patients, the side effects. For example, apart from some common side effects, what are the potentially severe, though it's rare toxicity like severe immune-related AE or bleeding or some of like significant proteinuria? This is something we'll discuss. And of course, something that may affect the quality of life, maybe rash or like fatigue, sometimes we also discuss with the patient. So these are the things that we will share when we try to make a joint decision or share decision with the patient.
Thank you, Stephen. I think we can go on with the case.
So as you could see, this patient, after a few cycles of atezolizumab and bevacizumab, the patient did have some response. You can see there's some resolution of the portal vein thrombosis and also shrinkage of tumor, and some of the satellite lesion also became smaller. So overall, this is more like a partial response. And also we continue the treatment till 6 cycles. Then you can see that finally the patient did develop progressive disease in October 2019. Again, now this time with the new liver lesions, which is confirmed in subsequent scan. So the patient was taken off the clinical trials. So this is the status that we could see in the December 2029.
Thank you, Stephen, again. And now the patient had the disease progression. What treatment options are available for this patient after atezolizumab plus bevacizumab?
I think at this moment, more for post-IO, we don't have many large-scale randomized study. At this moment, I think we have some prospective data on TKI like carboplatin, or recently we have an ESMO Asia readout on lenvatinib. And also we have some initial data on the pembrolizumab plus regorafenib. But whether we should routinely continue the IO or change to some other TKI, I think we need to await some more randomized data like the IMbrave 251.
And so then what did you prescribe?
So this patient, after taking off the study in December, we put the patient on the second line sorafenib, which you could see enjoyed around 7 months of kind of a disease control, and then the patient developed PD again. So we put the patient on some third line clinical trials. So this patient have some disease control again, but finally the patient developed PD and succumbed after recruitment to the third line clinical trials. So this patient had been put on, in summary, has some response to the atezo-bev, and then put on some of the TKI sequence or the clinical trials, did enjoy a period of disease control afterwards. So this highlight that nowadays our patients could maybe be able to receive 3 lines of the treatment. This highlight the longevity and also improved outcome of our patients.
Now I will present another case. This is a 61-year-old male with a family history of cancer. The father had a Kaposi sarcoma. The patient did not have any habits of smoking, alcohol, no allergies. In the past, he had HCV-related infection with HCV-related liver cirrhosis and was treated in 2017 with DAAs with a sustained virological response, SVR. As for comorbidities, the patient had also chronic pancreatitis and type 2 diabetes. So we evaluated the patient in April 2019 was admitted to the emergency room for refractory epigastric pain and GERD-like symptoms. He underwent a CT scan that showed something that was not expected. So multiple liver nodules, maximum 3 centimeters in segment 6 and 7, and abdominal lymph nodes. Then an endoscopic ultrasound was done with a biopsy of the hepatic ileum lymph node. Another option was to have a liver biopsy, to have an histological exam that was positive for hepatocellular carcinoma. The lab test showed an increased AFP, alpha-fetoprotein levels, 563 nanograms per milliliter, and the other tumor markers were negative. As for general conditions, the patient was in good clinical conditions with an ECOG performance status 0. The liver function was good, Child-Pugh class A, and the disease stage was a BCLC-C due to the extrahepatic spread. So, Stephen, would you consider this patient for an IO-based therapy? And as we were discussing for the other case, what patient and disease characteristic would you consider for this patient when selecting therapy?
Yeah, I think, Lorenza, this is a patient with disease outside of liver and also inside of the liver. So as mentioned, this is a BCLC stage C. And I think this patient is a candidate for the systemic therapy. And of course, in today's standard is the IO-based therapy. So in terms of the patient characteristics, when I decide, I think I will, as mentioned, review the comorbidity of the patient. If the patient generally have either high risk of hemorrhage, or the patient have more vascular comorbidity like proteinuria, hypertension, generally I would prefer more strike regimen rather than atezolizumab and bevacizumab. Another factor that I would consider is the treatment aim of the patient. We know that for atezolizumab, they have improved outcome, especially in the median overall survival, but there are not many long-term survival data. So if the patient would like to have more long-term survival, we may have more data supported by the strike in the Himalaya trial, which nowadays they have exploratory endpoint of 5-year survival. So these two factors I will consider when I decide on the choice of the treatment for the patient.
Thank you, Stephen. In June 2019, we evaluated the patient for the Himalaya study that was open at our center at that time, and the patient was randomized to the STRIDE arm, so a single priming dose of tremelimumab followed by durvalumab. Baseline lab tests were more or less within normal ranges. AST and ALT were within normal range, and gamma GT was slightly elevated, 51. AFP was increasing, 792 nanograms per milliliter. And on July the 12th, 2019, we administered the first cycle of STRIDE. And afterwards, we observed an important increase in transaminases, grade 3, increase in AST and ALT, but bilirubin was within normal range.
So, Lorenza, so this patient have elevation of AST and ALT, while the bilirubin was within normal range. So what was your diagnosis? And I think this likely one of the IRAE. So how do you address this AE?
So yes, our thought was first that the increase in transaminases could have been related to immunotherapy. We also wanted to exclude other causes, so we asked for other lab tests for viral infection, other viruses, and also we asked for an ultrasound to look at the liver. But in the end, as you were saying, the conclusion was that this was an immune-mediated, immune-related adverse event associated to the administration of immunotherapy. And in this case, I think it could be more related to the administration of the anti-CTLA-4, so tremelimumab, than to the durvalumab anti-PD-L1 agent. So considering that the patient was in good clinical condition and bilirubin was within normal range, we decided to watch and wait, avoiding to administer steroids. And indeed, in the following weeks, we observed a decrease in transaminases. And when both the transaminases, AST and ALT, were reduced to grade 1 in terms of increase, we administered the second cycle of the treatment that was with durvalumab as a single agent, as this is the case for the STRIDE regimen. And we didn't observe any further increase in transaminases. What we did observe after the third cycle of treatment was grade 2 hypothyroidism with increase in TSH. Again, this can be expected from the administration of immunotherapy, and we started levothyroxine.
So thank you, Lorenza. We know that this is one of the side effects of the STRIDE regimen. Could you educate us on are there any other adverse events associated with therapy with the STRIDE regimen, and how would you communicate these risks to your patients?
Oh yes, for immunotherapy, as we observed, the most frequent adverse events are hepatitis or increase in transaminases and hypothyroidism. But with immunotherapy, we can have other adverse events, like, for instance, skin toxicity with a pruritus, rash. We can have other gastrointestinal events like colitis, and we can have other endocrinological events other than the hypothyroidism. More rarely, we can have more severe adverse events like myocarditis or other immune-mediated adverse events involving other organs or tissues. So what I'm used to discuss with the patient is that in most of cases, immunotherapy is very well tolerated, and hypothyroidism is the most frequently observed adverse event. But in some cases, other events, maybe more severe, can be observed, can appear. And so it's important that the patient tells us every symptoms, every signs, every new signs and symptoms that occurs, so we can promptly treat them. So again, in most of cases we're tolerated, but it's important that the patients know that adverse events can appear. So it's important to have a good communication between the doctors, nurses, and the patients. So in this case, then we continued with durvalumab with no other adverse events, and we observed after 2 months of treatment a partial response with an important decrease in alpha-fetoprotein. So there was at the CT scan 49% disease reduction, and also AFP decreased from more than 700 to 73. So we went on with the treatment, and the partial response became deeper, and we observed again a further reduction in AFP that was almost within a normal range. And we went on with the treatment for approximately 2 years. We started in July 2019 and until August 2021. And at that time, we observed a disease progression with a new increase in alpha-fetoprotein.
So again, Lorenza, with a similar situation to the last patient. So what treatment options are available for this patient following the progression?
So the problem, as you mentioned, that we don't have robust data for second-line treatment after immunotherapy. At that time, we had a phase 2 trial open at our center that was single-arm phase 2 trial of cabozantinib. So we treat the patient with the cabozantinib. And what we observed was a stable disease that was very durable. Indeed, the patient received the cabozantinib for 2 years, from November 2021 to November 2023. And after 2 years on treatment, the CT scan showed disease progression. The patient was still in good clinical condition. The ECO performance status was 0, and the liver function was very good, Child-Pugh-A. We administer local regional therapy, stereotactic body radiotherapy on a lesion in the liver that was particularly increasing in diameter. But then we started a third-line treatment with sorafenib. And and very recently in October 2024. So I think what is important of this case that the patient received 2 years for 2 years immunotherapy, then for 2 further years cabozantinib, and then was able to start a third line treatment. So we had an overall survival from the initiation of a systemic therapy of approximately 5 years. And as you were saying about the other case, this is something that we were not used to see in the past. So a sequence of different treatments, in this case, immunotherapy, and then 2 lines of TKIs with a long-term survival for patients with advanced disease. And so I think this is one of the key messages that we can say, so that nowadays patients with advanced disease or unresectable disease can have long-term survival thanks to the sequence of different therapeutic options, immunotherapy and tyrosine kinase inhibitors. Stephen, what do you think?
Yeah, I fully agree with Lorenza. I think this highlights that nowadays our advanced HCC patients, they could survive quite long. And this is again highlight the quality of life, which is important. And also the liver function, we need to preserve it as much as possible so that they can be fit enough to receive the subsequent lines of the therapy. So thank you, Lorenza, for the sharing and the presentation.
Thank you, Stephen. And thank you all for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Thank you so much.
This program was presented by Medscape Education Global.